Thank you, everybody, for joining us today. I am absolutely thrilled to introduce you to our guest today, someone who is a true hero of mine. And if you've read Zoobiquity, you will know why I'm so excited. It's a book that completely changed how many of us view the connection between animals and humans. Dr. Barbara Natterson-Horowitz wears many hats as a cardiologist and evolutionary biologist at both Harvard and UCLA. She's also a leading voice for global health, chairing the board on animal health sciences at the National Academies and leading a cutting-edge lab that looks to the natural world to help solve human health challenges. Beyond her incredible academic career and best-selling books like Zoobiquity and Wildhood, Barbara is a champion for the very one medicine approach that we at Humanimal Trust hold so dear. And in fact, the last sentence of Zoobiquity sums that up perfectly. And it reads, because the fate of our world's health doesn't depend solely on how we humans fare. Rather, it will be determined by how all the patients, humans and animals, live, grow, get sick, and heal. Barbara, over to you.
Thank you for that lovely introduction. So warm, and I'm thrilled to be here. This morning, I'm actually coming to you from Los Angeles, West Coast. So I'm going to just jump in. And again, as you said, I would really welcome questions and a conversation. So I'm going to try to wrap this up. I will wrap this up by about, let's say, 45 after the hour, a little bit before that, and then we can chat. All right, so I'm going to share. Okay. All right. Are you seeing my screen?
Yes.
Wonderful. Yeah. All right. Species spanning medicine and the 21st century physician. So all of my work, really now for almost 15 years, is centered on a single idea, which is that the field of medicine is anthropocentric and problematically so. Yes, of course, there are a handful of model organisms that we turn to in the lab to understand medicine, but for the most part, all of this directed toward the human. But I think this is a problem, and that if we could expand the window through which we perceive health and disease to include the somewhere between 30 million and 120 million metazoan species with whom we currently, so extant species with whom we currently share the earth, if we could do that, and then if we could expand the window again to include the evolutionary history that has shaped the similarities and differences we have in terms of health vulnerabilities with other species, and again, the evolutionary history depicted by this phylogeny, that if we could do those two things, we could improve substantially how we understand the causes of disease, and we could be better, more nimble, more effective, faster at innovating solutions for treatment and for prevention. So those are big claims, and I think I now have probably 38 minutes, something like that, 40 minutes. So here's the plan for today. I'm going to quickly take you through my journey, how I ended up doing what I'm doing today and talking about these things and thinking about them. Then a little bit of a brief sort of review of sort of evolution 101 for medicine, and then just jump into some of the examples that I think make the case for this expanded perspective. I'll talk about the future a bit, and then we'll have a conversation, I hope. So I started my career as a physician, a cardiologist. I spent a couple of decades as a professor of medicine cardiology at UCLA. I had the privilege in 2005 to begin consulting at the zoo, the Los Angeles Zoo, as many fortunate cities around the United States, and I think around the world, physicians are, cardiologists particularly, are sometimes asked to perform the, transesophageal echoes to help with great apes and other animals at zoos. And I was just one of the lucky physicians who found myself in that really privileged position. And it was at the zoo that I really began to have an experience around comparative medicine that I'd really not ever experienced. I had studied evolutionary biology as an undergraduate. I had actually done a year, a master's degree before I went to medical school, but that all seemed remote and not necessarily related to what I was doing as a physician. Ah, okay, that's sorry about that. Until I started consulting at the zoo. And I saw a bunch of cases early on that really kind of got my interest, heightened my interest. One of which was an early case of a chimpanzee who had had some cardiovascular issues. And I remember doing the transesophageal echo and seeing this four-chambered heart and seeing these thrombi in the right atrium. And it reminded me so much of a human patient that I had imaged some months before. And of course, they both had an infiltrative and restrictive cardiomyopathy. And today I look back 15 years later and I think, why on earth was I ever surprised by that? And yet I was. And I think that surprise was a data point about how anthropocentric my medical education had been and what a blindfold that was. So I had an opportunity to really do it, see a number of cases, which again, I had taken care of in many human patients, but in non-human animals. And all of that became more and more interesting to me. I spent a lot of time, not just at the zoo, but with veterinarians in different spaces. I started attending conferences, collaborating on projects. And increasingly, because I was a professor of medicine, I was asking myself, what am I learning? It seemed like it was this continent of knowledge. And yet I did not know how to use this, my ever-growing comparative knowledge to improve human health. And I'm a physician, I'm not a veterinarian. And so that is my charge. But I didn't know how to do it. I did not know what tools were available, what needed to happen. So I started thinking and writing and trying to develop this idea. Of course, the popular science books that were mentioned. And I started doing a lot of education, developing courses, conferences, the Zoobiquity conferences I'm very proud of. We started those in 2011, and those were to bring together medical schools and veterinary schools, really senior faculty, to come together so veterinary cardiologists and human cardiologists could have conversations about atrial fibrillation and cardiomyopathy, to have veterinary oncologists and human oncologists talk about the management of glioblastoma or lymphoma, et cetera. And I saw that. I think Katerina Labrador is on this call. I was very excited. So we had a Zoobiquity conference. We've had them all over the country and in some places around the world. And we had a marvelous one in Portugal and Lisbon several years ago. In any event, these were some of the efforts that I was trying to kind of explore. Well, how could I take this knowledge and really use it to improve human health? And even if I was starting with medical education, so I started lots and lots of courses, both at Harvard and at UCLA. And that was, these are some examples of these are a couple of cardiovascular cases presented at Zoobiquity conferences. But I also was publishing in the medical literature, in the scientific literature. Really, I was trying to, as much as I could, expose my colleagues to the power of broadly comparative thinking, something that, a veterinary perspective, veterinary medicine is so deeply rooted in the comparative approach, and yet it has been lost, I think, for the most part, by most of human medicine. So one of the things I realized quite early on was that I needed a framework for research. I did not really even have a sense about how to structure a question, a research question that would draw broadly on comparative medicine and evolutionary theory and turn it into something that would have translational benefit. But fortunately, I had studied evolution as an undergraduate and in grad school. And so now we're going to have a tiny bit of evolution, and then I'll jump into the framework that I came up with. So we'll start. All right. Okay, so before I show you the video, the framework that I use was based on the work of Nico Tinbergen. So Nico Tinbergen won the Nobel Prize in Medicine and Physiology in 1973. And what's interesting about that is that Nico Tinbergen was an animal behaviorist. He won it along with Carl von Frisch. and Konrad Lorenz, two other animal behaviorists. But at that time, it was radical to give the Nobel Prize to animal behaviorists. I mean, the years before, the prize had been given for the discovery of the Krebs cycle and for, other very reductive biological, discoveries. And here was animal behavior. And the answer really to that, the reason given at that time was that there was belief that animal behavior might be a way of unlocking the mysteries of the human mind, which I think it hasn't yet, but I think it will soon. I think that was a very good instinct. In any event, Tinbergen's most enduring contribution, in my view, was this 1963 paper on aims and methods of ethology, where he essentially reprimanded the biological community for responding to questions about why something was happening with reductive mechanistic explanations. And of course, we do this in medicine. We do it all the time. A patient asks me why they had a heart attack. The answer is invariably a discussion of lipid, dyslipidemia, and atherosclerosis, and blood clots, etc. And those are important explanations, but they are not why explanations. What Tinbergen asserted was that in order to explain why, one needed to look at that biological feature and explain how it conferred survival benefit or reproductive value. So really an evolutionary framing. And of course, this is not something that we do in medicine. And what Tinbergen asserted was in order to really get at that adaptive component, one needed to look at the evolutionary history, which is essentially what a phylogeny is. It is an evolutionary history of how these species, the selective pressures that shape the phenotype that we see as the extant biological reality. Okay, evolution 101, the Big Bang at 14 billion years. We have the Earth at about 4.5 to 5 billion years. I don't know if you saw the moon just over there on the left, but it's not until, and we used to say 3.7 billion years ago, now it's 4.2, that we have single-celled organisms. We have the earliest life on Earth. And of course, then we have photosynthesis comes online, and eventually there is so much oxygen in the environment that one of the first extinction events, the Great Oxygenation Event, occurs at about 2.4 billion years ago. And then we're going to have a series of glaciation events and all kinds of geological events until 600 million years ago, when we first see enough multicellularity and triple plasticity that we have early animal life, the beginning of metazoa. And metazoa, then we have the beginning of the Cambrian explosion, some about 50 million years later, and the terrestrialization and diversification of life on Earth. And so we see that most of the species, the vast majority of animal life that we have on Earth today, originated during that period. And you'll see at the end of this video that we see it's 23 million years here, and we see only one primate. And we don't, of course, see humans. And the reason for that, of course, is that our species originated only about 200 to 300,000 years ago. Here, this is probably a common ancestor of humans and gorillas or orangs. And the point is that it's always, I think that as physicians, there is a kind of very loosey-goosey understanding of evolution, and the newness, the how recently our species appeared. It is lost. And the meaning of it is so profound for medicine. And I think really very much one of the barriers to advances in one health and one medicine, which is, remember that Darwin taught us that evolution works through descent with modification, which means if you have species A, B, C, D, E, F, and G, right? Species G is different from F, but mostly the same. And F is, different from E, but largely the same. So the idea is that they're incremental changes, essentially that there's far more commonality than there's more similarity than dissimilarity. And yet there is so much, there's such a default to humans being different, humans being unique, humans being exceptional, that influences scientific thinking. And I think we need to work to really flip that, that our null hypothesis should be it should be the inverse. We should assume commonality as physicians when it comes to thinking about health vulnerabilities that we share with other animals. We shouldn't default to dissimilarity. But most physicians, when I speak to them about any disorder, their first instinct is to assume that it's uniquely human. Quickly, they kind of correct that, but I think there's something very profound about understanding, deeply understanding how recently our species appeared on Earth and what that means in terms of our shared biology and what that means in terms of our shared biological vulnerability to disease. A fun way of just featuring this is a video that considers, if you imagine that life on Earth is an airplane trip between Southern California and New York City, we would have we'd have life on Earth coming on board around over Arizona. We'd have photosynthesis in Western Colorado, but of course it wouldn't be until we were in Western Pennsylvania that we would have that sufficient multicellularity and the beginning of life, of animal life. And of course, then in that case, we can then see the state, a trip across Pennsylvania as the evolution of animals. We've got the dinosaurs, we've got the extinction event, we've got our common ancestor with chimpanzees, and then 570 feet before touchdown in New York City, Homo sapiens arrives. Okay, so that is, I think, I think it's an important reframe that would really help us, help me in my efforts to bring the human biomedical community into this important and powerful One Health, One Medicine conversation. Okay, so let's go back to Tinbergen and the phylogeny for just a second. So because phylogenies were, Tinbergen emphasized evolutionary history, it got me thinking about the framework that I needed to develop. And I eventually developed a system for thinking about the connection between human and animal health through two forms of phylogenetic models. One which focuses on causation and the other innovation. So let's start with causation. And I call my causation model the outside-in model. And it goes like this. I say that if a trait such as vulnerability to disease exists in, let's say, mammals like us, birds, reptiles, amphibians, fish, and remember, each of these tips represents an extant taxa, that if the trait exists broadly across these species, a hypothesis is that the common ancestor also had this trait and that the trait conferred some biological benefit and therefore had been conserved, right? So this would be, this is the outside-in concept. And if the trait is vulnerability to disease, then this would be a way of beginning to understand why we're vulnerable to that disease. So let's take as an example a very common cardiovascular issue, which is vasovagal syncope. Some people call it fear fainting. It is, very, very common. You see it, for example, when people are giving blood and somebody, passes out. Okay, so there is nothing adaptive for an individual human being to have a vasovagal fainting episode. As you can see, there's no way to conceive of this physiology as having adaptive benefit. And in fact, it seems counterintuitive. When I used to teach the course pathophysiology to the second-year medical students, I would say that vasovagal syncope is paradoxical. Why? Because we expect fear to induce tachycardia. But what do we see? Well, what happens with vasovagal syncope, this fellow is giving blood. He is, he's experiencing fear, but there is, instead of a tachycardia, there is a bradycardia. And instead of a vasoconstriction, there is a vasodilation. And that combination results in underperfusion of the brain and fainting. Okay, so I used to say this is paradoxical. Well, it's only paradoxical if you are an anthropocentric oriented person. If you begin to explore more broadly what I learned early on, this is one of the first phylogenetic models I built, is that I was able to find animals from other mammals all the way through fish, actually, in which most of the time, fear would induce a more traditional fight-flight response, but that occasionally there could be this bradycardia and vasodilation. And in fact, when I mapped it on a phylogeny, I was able to really see how broadly this trait existed. And of course, going back to the outside in, when you see a trait broadly across a phylogeny, one hypothesis is that the common ancestor had this trait and that the trait was conserved because it confers biological benefit. Well, what could that benefit be? Well, that answer, becomes the adaptive hypothesis, and I'll quickly zip through what I believe it is in the case of vasovagal syncope. It turns out many of our most ancient predators, our underwater, the hunters who hunted our fish ancestors, tracked their prey by tracking the electrical signal off of the EKG, and in fact are equipped with these electroreceptors, these spicules. And in that case, if the hunter is tracking the EKG of the prey, if there is an abrupt sort of cessation or profound slowing of that signal, then the predator no longer can track the prey. And that becomes an adaptive advantage. And we see, this is seen, actually, there's a number of fish that will kind of quote unquote play dead in response to people cleaning out the tanks. In any event, those are fish. We're mammals. Let's look at another mammal. So this is a fawn, right? A young deer. Back in the 1970s, some scientists put telemetry leads on these young deer, and they found that baseline heart rates were 180 beats per minute. They then frightened the fawn, found that the heart rates plummeted, and in conjunction with that, there was this tonic immobility. Well, I bet as you're looking at this, and you know that what I asked early on was, I said, what is the adaptive hypothesis? What could the benefit be? And you're probably formulating some ideas. Well, here is a video of a hyena who's digging into an antelope that has just been captured by this young cheetah. The hyena had grabbed it from the cheetah. There we go. I should have directed you to look at the antelope and not the hyena. The point is that we'll look at it one more time. That the antelope is immobile, right? It's tonic immobility, boom, and that has allowed it to survive that episode. Whether there was a bradycardia or not, I don't know, but there's no question that tonic immobility was life-saving, that it would fulfill Tinbergen's criteria for adaptive. There's a second framework that we can use for understanding causation, which I also credit to having been inspired by Tinbergen, and that is to begin thinking about traits, disease vulnerability as the trait. So it's one thing if the trait is a bradycardia in response to fear, but if we're talking about disease vulnerability, how could disease vulnerability ever be adaptive? How is that possible? And the answer to that question is simple, actually, and it comes down to the reality that not all pieces of phenotype are adaptive. And this concept is based on the reality that biology is constrained. Biological systems are constrained. And when there is selective pressure for a certain trait, the biology that produces that trait, that piece of the phenotype, may also bring in biology that's non-adaptive. In fact, it may be maladaptive. If it's severely maladaptive, then that phenotype won't survive. But it's a compromise. The phenotype ultimately represents a compromise. My undergraduate thesis advisor was Stephen Jay Gould. I was very lucky. I was an undergraduate at Harvard. E.O. Wilson was my freshman biology teacher, and Stephen Jay Gould was one of my teachers as well. And he and Richard Lewontin came up with this architectural metaphor for the arches and the spandrels, in which they said, when you are building these palisades of arches, as we see in San Marcos Square in Venice, an inevitable, you cannot, when you build this, you are going to end up with spandrels. And the spandrels are not the purpose, but they are the product of this constrained piece of block marble. And that is essentially what disease vulnerability it's a product of selection for biological benefit. Selection for biological benefit produces complex phenotypes that have as a component of them non-adaptive biology. Now, that is what we call an evolutionary trade-off, and everyone knows, we all learned this early in school. I think they teach this in undergraduate courses, apparently also in high schools, AP Bio, that sickle cell disease is an example of a trade-off, right? We know that the sickle cell disease is a devastating illness in which individuals have these blood clots forming in arteries and arterioles that create all kinds of problems. And but that the reason that this it's a point mutation, but the reason that it has been sustained, yes, homozygotes develop the disease, but heterozygotes have actually resistance to falciparum malaria. So so being vulnerable to sickle cell disease, having this in heterozygotes, homozygotes rather, is balanced by the malaria resistance in the heterozygote. So this is, sickle cell is a monogenic, kind of easy, you can wrap your head around it easy. But what about polygenic human pathologies, the ones that we deal with as physicians? I'm talking about heart disease and cancer. Well, cancer actually can be framed in using the same trade-off concept. There was a paper that was published in 2000, which continues to be the most cited cell paper of all time. It was Hanahan and Weinberg, where they took, you think about how heterogeneous cancer is, right? You can have it's leukemia, it's brain cancer, it's breast cancer. What does cancer have in common? Well, these hallmarks of cancer, right? And all of which have to do with conceiving of a tumor as multiple individuals who are coming together, and each individual has its own fitness concerns. And when you have a community with individuals whose interests may not be fully aligned, there need to be rules that govern how these communities of individuals interact. And what's interesting is that several years after this paper was published, some evolutionary biologists noticed that the same characteristics that are the hallmarks of cancer are also the hallmarks of organisms that had transitioned from unicellularity to multicellularity about 600 million years ago. And so the concept became that vulnerability to cancer, that animals, not just animals, but life became vulnerable to cancer as a consequence of that there were benefits of multicellularity. The trade-off was this vulnerability. We can apply this way of thinking to any disease. I'm about to publish a paper about using this framework for atherosclerosis. So that was a whistle-stop tour through how we can use that outside-in phylogenetic modeling to think about the cause of disease. But now I want to kind of pivot to how we can use a phylogenetic model. Actually, it's going to be inside out to think about innovation. So here we're looking at a phylogeny, and we are starting with, let's say, a common ancestor. And what we're seeing over here is this process of speciation, right? We're seeing these new species being formed, and we see the ones that are extant, the tips that we're seeing today. We see that there are some branches that end, right? Those are species, those are lineages that did not continue. But I want to kind of look at this again. And this time, as you're seeing this happen, think about what is actually going on. Why does speciation occur, right? Or why do we have biodiversity? We have biodiversity because speciation produces biodiversity, and speciation occurs because environments change. And we know that organisms that have the characteristics that allow them to be best aligned to that environment, they have characteristics that allow them to counter existential threats and to maximally leverage the resources of resources, the food, the living situations, those that can leverage those resources to improve reproduction. organisms that have those characteristics survive. And because environments change, the solutions that the winning phenotypes must contain change. And so when we think about biodiversity, right, we often think about the external. We think about the beautiful animals in the rainforest and all of the flora and fauna. But it also includes the physiology, the internal physiology that is optimized to help that organism in that environment counter the existential threats, be they infectious, whether they could be thermal extremes, they could be lack of food resources, etc., and have characteristics to allow them to physiologically maximally leverage the resources in the environment. And so we end up with this multitudes of physiologic solutions that exist across the animal kingdom. In some cases, those physiologic solutions may have solved challenges that we have found to be intractable, that the best of our biomedical research cannot yet crack. So the method that the approach rather that we can use that's based on this is actually based on classic bio-inspired engineering. And I know many people have seen this example. This is a picture of the bullet train, the Shinkansen train. It debuted in 1964 in Tokyo, was a major success, but it had a problem, it had a flaw, which was when it entered and exited the station, accelerated and decelerated, there was a lot of vibration causing noise and damage. But as the story goes, one of the engineers on the train himself was he was an ornithologist, he was a weekend birder, and he knew that so he knew about the kingfisher, or he was a fan of the kingfisher. And of course, the kingfishers are known for these beautiful, sleek beaks that have evolved to maximally leverage, right, the resources in the environment. And by that, I mean that they are able to pierce the water without inducing rippling and chasing away the food, the fish that are underneath, versus, let's say, a blunted beak, right? And so, as the story goes, they redesigned, reconfigured the nose of the bullet train to conform to the kingfisher. Well, this is the concept that I think we can and should be applying to human medicine. There's actually a fair amount of work that's already been done in cancer, but I'm a cardiologist. I'm not a cancer doctor. So, here are some other diseases where there is current work going on. But I want to give you an example from heart disease. All right, so there are a number that I'm working on, but let's talk about heart failure particularly, and particularly a form of heart failure that is the leading cause of heart failure in women. It's called heart failure with preserved ejection fraction. It is the fastest growing form of heart failure, more cases every year, sort of outpacing others, and of course, particularly affects women, particularly older women. And the pathogenesis is complex, but in simple terms, you have a normal heart here, left ventricle, right? We've just cut the heart open. We're looking from the inside, left ventricle, right ventricle. And if the patient has high blood pressure over a period of time, that ventricle begins to thicken like a muscle thickens when it's overworked. And when the muscle thickens, it becomes stiff, it becomes fibrotic, it becomes stiff, and that translates into a patient who has high blood pressure, a thick ventricle, and she is short of breath. She has exercise intolerance. She has symptoms of heart failure, in some cases, very severe heart failure. It's very hard for her to move from the bedroom, let's say, to her kitchen, that sort of thing. So I asked myself what non-human animals might have evolved adaptations that are relevant to HFpEF. And the giraffe came as an early a kind of possibility. And the reason that the giraffe became a possibility is because, of course, I think it's well known that the giraffe has the highest blood pressure of any animal on Earth. This is a normal blood pressure. This is not pathological, right? This is a healthy adult giraffe. And the reason for that is simply that the heart, the left ventricle that we looked at before, is down here. But of course, the brain that it must perfuse is up here. That is 2.5 to 3 meters of vertical afterload, right? And that is pressure on the ventricle. And so The giraffe has a ventricle that is thick. It thickens in response to the need to perfuse the heart, to perfuse the brain. And you can see, I don't know, I'm not sure if we have physicians, veterinarians, but for those of you who are not physicians or veterinarians or cardiologists, I will tell you that this is a giraffe heart, and it is this is the ventricle, this is the cavity, and you can see that it's very, very, very thick. Now, when I look at that, if I saw something like that in a human patient, on necropsy, I would say, oh my God, this patient must have been so symptomatic, that kind of thickness. And of course, that's what you see, I have seen many times in human patients. And yet, what do we see in the giraffe? Well, we have this thickened ventricle, right, in response to the high blood pressure. And yet, the giraffe must, not can, let's say must, in order to survive, flee predators between 30 and 40 kilometers an hour. So this is impossible to reconcile as a human cardiologist. If I'm anthropocentric and I'm not thinking, how on earth would this be possible? Well, this is, again, where a one medicine, a one health approach, training medical students and biomedical investigators that there may be solutions that exist in nature, beginning to teach about evolution as a basic science for biomedical research. Because when I looked at this video, at I knew that there must be an adaptation in the heart of the giraffe that allowed it to have a thick ventricle and flee like this, thick but not stiff. Okay. And that became a project that eventually ended up, I don't want to talk too much more about this. We can at another time. But we all learned in elementary school that there are advantages of having a long neck if you're a giraffe, right? Accessing the food resources at the tops of the trees. Also, remember, giraffe many of them are on the savanna, and having a long neck allows you to scan for predators. So there's existential protection that's conferred. So those are selective pressures favoring a long neck. But if that long neck came at the cost of the animal being slower, of having exercise intolerance, they would be picked off by predators. Those would not have survived. So giraffe evolution must have been a kind of crucible for evolving a solution. And the story, I think, goes something like this. This is a modern giraffe on the left and the okapi on the right. Okapi and giraffe are the two extant remaining species of Giraffidae. These animals shared a common ancestor 11.5 million years ago. And the ancestors of the modern okapi, they actually migrated to the Congolese rainforest. And in the rainforest, there's no real advantage to having a long neck, and it doesn't. But of course, the ancestors of the giraffe migrated to the savanna, where the long neck has these selective advantages. Well, this becomes a perfect opportunity to use comparative genomics to really pinpoint what is going on in the heart of the giraffe that is not happening in the heart of the okapi. And so this is, to make a long story short, a group, Chang Lui's group, ended up publishing chromosome level assemblies of a giraffe, and they compared it with over 50 ruminant species. And when they compared okapi and giraffe, they found that there were several unique giraffe mutations, one of which is a mutation in a gene, FGFR1, which plays a role in cardiac fibrosis and in hypertension. And what they ended up doing was very clever. They used gene editing, CRISPR-Cas9 editing, and they took the mutations in the giraffe mutations of FGFR1, and they CRISPRed them into a group of mice. They had their giraffified, that's my term, giraffified mice and the wild type mice, and they infused both populations with angiotensin 2, which made them hypertensive. And then they measured their blood pressure, and then they looked at their hearts. What they found was so what we're looking at here are this is the giraffe, right? This is the wild type, that the blood pressure was blunted, right? There was real resistance to hypertension in the giraffe group, but more importantly, and by giraffe group, I mean the mice who had the giraffe FGFR1, there was suppression of cardiac fibrosis in the mice that had the giraffe FGFR1 versus the wild type. Well, this was very exciting to me, and it continues to be very inspiring because this is the beginning, the possibility that with new emerging technologies in gene editing, that we may be able to find adaptations within the physiologic biodiversity of life on Earth and bring them through gene editing and related methodologies to the human bedside. This is very profound. We're not there yet, but I think we are on the brink of this. And it's not just the heart. I must say, since I'm interested in women's health, if the giraffe, if male and female giraffes evolved adaptations to protect the heart from the adverse effects of high blood pressure, of hypertension, then one must also assume that the female giraffes must have evolved adaptations to protect fetus and mom from the adverse effects of hypertension during pregnancy. In our species, in humans, gestational hypertension is the leading cause of maternal and fetal demise. And we know that the giraffe, right, they have healthy fetuses and healthy calves, and mom stays healthy. So there must be adaptations. Again, no one will think of these to look to the animal kingdom if we're training medical students in an anthropocentric way. But imagine a world in which medical students were trained to think comparatively the way veterinary students are, the way the way I think truly biological thinkers recognize that there's a value within through that evolutionary thinking and thinking about biodiversity as a source of solutions. What a powerful opportunity that is. I'm going to, I think I'm going to skip the ventricular. I have another cardiac example, but I want to kind of pause for a moment and just begin to take a step back and say that 15 years ago, when I started on this journey, which was not something I had expected, and I look back and I think if I hadn't been invited to do the transesophageal echoes on the great apes at the Los Angeles Zoo, this might not have happened for me. Yes, I was very interested in evolutionary biology, and I think had I not had that training and background, I may not have been able to make some of these connections. But what happened to me was serendipitous, and that is just not. We can't afford. We have too many health challenges, human health challenges, and animal health challenges for this kind of for this to have been serendipitous. And so I've been working pretty much exclusively to try to make the case to other physicians, to medical schools, not just physicians. It's the entire human health community. It's dentists and podiatrists and psychiatrists and psychologists, that every aspect of animal biology and animal health is relevant to human health, because for the obvious reasons, we are all members of metazoa. And so I like to, at the end of my talks, just extend an invitation and to join me in this, and to, if you have ideas, and and I think the time is right, but it will not happen unless there's a push. I expected, if you'd asked me 15 years ago, I would have said by now this would be incorporated into medical school curriculum, and it's not for the most part, which is okay. There's just a lot more work to do. So I'm going to end by just making a couple of points. There's some really good news. One of the most exciting things that is happening is this Earth Biogenome Project and related projects. The Earth Biogenome Project has committed to sequencing all of the eukaryotic life, I think by the end of the decade, so 2030 or beyond, and it's rapidly happening. This will open things up, but there are many other projects that I think there's a lot of good news in terms of what we know and how the natural world is being explored. And I think the big challenge is finding ways to break down the barrier between traditional biomedical education and research and this expanded way of understanding. And so I'll just end by saying that no one explained or recognized the power of the natural world to answer questions better than Charles Darwin himself, who in The Origin of Species wrote that natural selection is a power incessantly ready for action and this is my favorite part, immeasurably superior to man's feeble efforts. And with that, I'm going to stop sharing and would welcome questions and conversation.
Absolutely superb. I mean, Friday afternoon, and my brain is fried. I don't know how I'm going to be able to relax later, Barbara, but absolutely fantastic. I loved it when you said, we need to assume commonality. I think, sadly, many, especially those in the human health community, are not ready to assume that. But at least what we're trying to achieve, and it sounds like you're doing exactly the same, is trying to help them consider at least the commonality before that. So it's like the first step. So I'm going to pass over. I'm sure there are many questions that people have. So please, if you could raise your hand or pop it in the chat, I will try and find you with your hand up, and Mike will assist me. I think we have Sreya has got a question.
Hi, yes, I'm so sorry. I'll just switch off my camera. Uh, I'm a psychiatrist working in NHS. So I was just wondering how you feel this would translate to mental health, because obviously humans are much more complex than our relatives in other species.
So it's as though I put you up to, I've never met you before, but that's a wonderful question. It's the book that I'm working on, and for several years have been working on, The Animal Origins of Human Mental Health. There are many, many ways. I will give you two, but I think the opportunities to understand mental health are massive. And in fact, it's interesting that the fact that the Nobel Prize was given to these animal behaviorists because of the potential for a comparative approach to inform really human mental health. I think we're on the brink of making that happen. So, number one, if we look at affective disorders, if we look at just depression per se, if we look, let's go all the way from humans to teleost fish, right? We know that zebrafish are used in the lab all the time as an animal model for developing drugs. And if you look at some of the protocols that are used to induce depressive-like syndrome in zebrafish, we see that we have a roadmap to really beginning to understand what causes some forms of depression in humans. For example, chronic social defeat is one of the models that's used to and reliably can produce what I would call neurovegetative symptoms in a zebrafish. The criteria that they use for depressive-like syndrome includes they stop eating, they withdraw, they have motoric slowing, right? All the criteria that some of the criteria that we use for neurovegetative depression. And it's interesting that social defeat is what induces it. Chronic unpredictable stress is another one of the models that is used, right? The protocols. If we take just those two elements and we bring them back to the psychotherapy suite, what we are looking at, I believe, are the fundamental reasons that we see in human life that experiences of humiliation and social defeat, and that we can begin to frame what happens in human life through these ancient pathways that are present in teleost fish, that are used, that we rely on for the development of drugs that we trust, but that actually we can turn to for insights into why certain human experiences and human conditions, social conditions, familial conditions, occupational conditions, seem to elicit and pull up these kinds of either mild, moderate, or severe depression. So that's one. Number two is stigma. So a former director of the National Institutes of Mental Health identified the stigma of mental illness, as the leading barrier to advances in mental health. And he has if you read this essay, it's very compelling. One of the things that I do in my courses, I teach I teach fourth year Harvard medical students. We have a comparative medicine course, and one of the things that we do is we look at hoarding behavior in non-human animals. We look at yes, we look at some pathological hoarding, but we also go into the natural world where hoarding or caching is very adaptive, right? It is a behavioral hedge against starvation. And we then go and we look at the neurobiology of hoarding behavior in non-human animals and in humans. And we begin to see the alignment of that neurobiology, the remarkable alignment. And then we take a step back and we ask, why is hoarding so stigmatized in human life? And yet when we look at it from, when we recognize, when we see the shared neurobiology in non-human animals, there's no stigma at all. And of course, there's no answer to that question, but I have the students write on that for their final exam. And it has become one of the most, when I get notes from students who have been through the course, that experience is beginning to think about the animal origins of mental health challenges, how profoundly that can destigmatize. I think there is a real pathway there. I haven't worked all of it out yet. Even recognizing that non-human animals, we see self-injury in certain conditions and understanding why that happens and what veterinarians in zoos, for example, can do to prevent that. That has relevance to self-injury in humans. There are certain animals, great apes and some marine mammals, who under certain conditions engage in a stereotypy, which is self-induced vomiting. It's called regurgitation and reingestion, and it has stereotypic characteristics. It's repetitive. It appears to be a kind of self-soothing behavior. I think that has relevance to bulimia nervosa, particularly. We know that patients describe the self-soothe of both the ingestion and the regurgitation, and it goes on and on. There are at least, I have probably 6 or 7 DSM diagnoses that for which I think there are strong parallels in not perfect parallels, right? Different species, but that have salience and can help not just with the science, but also with the stigma.
Yeah. No, thank you, Barbara, and thank you for asking that question. It's so true. I mean, we've looked a lot at this as well, and we know that there's certain things like ADHD, PTSD. Again, there's so many commonalities between humans and animals. Our chair, Mary Fraser, who's a vet and wears many other hats as well, has asked a wonderful question. But Mary, I'm not going to read it out for you. I'm going to let you ask it yourself.
Thank you. I thought it was easier to write my thoughts down so I knew what I was going to say. Thank you so much for a marvelous talk. That was just wonderful, and everything that you're doing. I just wonder how we can win over more medics. So first of all, I'm definitely going to share your cardiology examples and all the other examples you gave us with the cardiology colleagues of mine. But I am sometimes told, it's not relevant to my specialty, whether that's acute medicine, respiratory, GI, whatever. So how can we be more open about everything you've talked about, but how this is relevant to daily clinical practice?
Yes, so it's a great question, and I think there's not a single answer. I think every case is different. There are certain conditions where I think which are really in which animal knowledge can help advance a research agenda. I'll give you just a couple of low-hanging fruit. In cardiology, one of the big issues with atrial fibrillation, which is the most common human arrhythmia, is that patients develop blood clots in their left atrium, in their left atrial appendage, and that causes strokes. I mean, thromboembolic events, really, really huge issue in AFib. And but I recently published a paper just a couple of months ago, Arrhythmia Across the Tree of Life, and I had the opportunity to work with some brilliant veterinary cardiologists, and I learned that in equine AFib, and horses can develop chronic AF, they never, literally never develop clot. Now that is whether we call it a natural animal model or, I mean, they're domesticated animals, but still that is a natural animal model of resistance to probably the most dreaded complication of the most common arrhythmia in our species. So that's sort of, if I were doing research in AF, I would certainly be interested in pursuing that. That's sort of one. Okay. On the other hand, if we're going to just stay in the cardiology realm, I think, well, actually, let me move away from the cardiology realm quickly to cancer, because there is I'm very excited. I'm going to be doing a keynote in Montreal, and there's some veterinarians that I worked on the Lancet. It was the One Health. It was the One Health Commission. We had we literally just we just published this, but and they work there. It's part of the group that those belugas, this famous case of the belugas in St. Lawrence Estuary who were dying, and many of the females, I think it was like 25 or 30%, were found to have ovarian and I think mammary and ovarian cancer, which are really apparently rare for cetaceans, that like leukemia, lymphomas, more blood-borne malignancies. And of course, it turned out there were aluminum smelting factories that were spewing whatever what's polycyclic aromatic hydrocarbons, those carcinogens, into that riverway. And of course, the humans who were living on the coast were also affected. So I think that is, that idea that we share this vulnerability. It's the outside, and we have this common vulnerability. We're in the same environment, and yet we don't think to turn to the animals living in our homes, around us, as a source of insight for environmental dangers. And part of that, and I'm sure you know that there are many people who are working on this, Peter Rabinowitz and others, the Canary database, but there still is not an integrated way to know, to track the health of your animals and relate it to your health. There's a program in Boston called the Boston Urban Rat Project. And it was started decades ago, and it's genius, where they look at lead levels in rats that are, captured for whatever, and they've been able to correlate that to, blocks in the city where there is still residual lead in the paint, so that, which is obviously hugely consequential to human health. Those are the kinds of things, but it's a way of thinking, and I think that we have to. I mean, I've devoted my life to this, but I think that I think veterinarians are the leaders in this, have to kind of hold the hand, have the interest of physicians enough, and then figuratively hold their hand and work together to see these things together and have these conversations that can cause the light bulb to come on. It's doable. Again, I'm so excited that Katerina is here. Katerina Lavrador is in because she reached out, and so Katerina, I don't know if you want to, anyway, I don't want to embarrass her, but she coordinated this Zoobiquity conference in Portugal. We focused on women's health, and physicians who attend, medical students who attend, they are transformed. Honestly, I don't think the veterinarians are, but they are helping to transform the human health community. And I do think I think the leadership is going to go in that direction.
That's fantastic. Thank you for asking that, Mary, and thank you, Barbara. We're going to have to wrap up soon, so just one more question we've had on the chat. I don't know if Lana wants to actually speak about this herself, if she's still here. Lana, are you?
Yes, I am.
Brilliant.
Hi there. Sorry, I don't seem to be able to turn my camera on, but hello.
Hi.
Hi, Barbara. I've actually just followed you on Instagram. I'm a canine wellness professional, and I specialize in dogs with, as you can hear in the background, with gluten sensitivity. Hang on, let me just close this door. I really struggle to manage my dog who's very gluten sensitive, and I also struggle to get other vets to understand the severity and sensitivity of dogs with gluten sensitivity. I've had to look to the celiac community to try and better understand what it is, how my dog is feeling, and how to better manage him, and also help gather information for a lady who I call the Erin Brockovich of Border Terriers, because she is absolutely fabulous, and she's working on a genetic test with other neurologists in the canine space. She spearheaded the Slem Shaken Puppy Syndrome test, and now we're working on building a database for this genetic gluten intolerance. And I don't know how aware as vets you are of it, and I don't know how to find all of the best information and papers and research on it, because I am trying to support her research and help the neurologists, and also help other pet parents in this space who don't understand, because my vet didn't know about it, the specialists don't know about it, and up to 50% of Border Terriers are suffering from this as one breed, as an example. Sorry, that's quite a lot.
No, Lana, that's concerning and interesting. I don't know if there's anyone here who can answer that, but what we certainly can do, Lana, is take that question away with us. And if you write to we've got a slide with our admin at Humanimal Trust email on. If not, if you go to our website, and you will see that, or Mike can put it up on the chat, our website address and our email address. We will try and do our best to get that question out to the vets in our community, and human professionals as well, to see if anyone deals with those commonalities between humans and animals with celiac disease. But is there anyone here, Barbara or Mary, for example, who'd have any response to Lana on that?
I don't have knowledge of that. The only connection that I was making as you were speaking is that I do think it's more and more human medical conferences on topics, and I know that there are, there's lots of interest in this issue in humans. They do welcome veterinary, presentations about the animal expression of these diseases. I've seen that more and more, so that might be a place to submit an abstract and present, because then that's a way of getting the attention and visibility of experts in a community that might be able to help.
That's brilliant. Thank you, Barbara. Mary?
Yeah, so I'll just put it in the chat there. So I'm aware of the condition in Border Terriers, but at the moment I can't think of anybody who's specifically working in this area, but I will go and do some research and see what I can find.
Brilliant. So Lana, if you drop us an email, in fact, Mike, I don't know if you want to put your email on there, or the admin at email on the chat, so that Lana can get in touch with us, and then we can see if we can find out anything for you, because that's what we're all about at Humanimal Trust, is about collaboration, and trying to get people together so they can really, explore what we can do for the benefit of all patients, both humans and animals. So thank you very much to our incredible speaker, Barbara, not just for your inspiring presentation, but for all the work you are doing. It's absolutely phenomenal. Thank you for your time today. We truly appreciate it. And thank you to all those who've spent their Friday afternoon or morning in different parts of the world with us today, listening to this. We hope you have an absolutely wonderful weekend. Thank you so very much. Take care and goodbye.
Thank you.